Okay, thank you, Dr. Muhammad Al-Maqadi, and for the speakers, Dr. Firas Al-Fireh, Dr. Muhammad Salama, and Dr. Jennifer Brown for the excellent session we had. And now we start the last session of the day. Before we start, I would just want to remind everyone to please participate in the public chat and write your questions. We have, mashallah, close to 5,000 attendees. Our first talk today will be about artificial intelligence approaches in hematopoietic stem cell transplant. This will be delivered by Dr. Shahrukh Hashmi. Dr. Shahrukh Hashmi is currently the chairman of hematology and oncology at Sheikh Shahbout Medical Center in Abu Dhabi, UAE. He's an international authority on graft versus host disease and BMT survivorship with greater than 100 publications in peer-reviewed journals. So without further ado, please, Dr. Shahrukh, you can start your talk.
Good morning, afternoon, evening. It's a great pleasure to present artificial intelligence in transplant. I'm at SSMC in Abu Dhabi, also supplementary consultant at the Mayo Clinic in Rochester, Minnesota. I have no relevant conflicts of interest. Some other disclosures not related to the talk are given here on this slide. Today we're going to talk about AI in hematopoietic cell transplantation. And before that, I'm going to give a little bit background of the overall approach of AI in healthcare currently. As you can see in the slide, the AI, which I will refer to as machine learning, which is the #1 area of AI in healthcare, spans over 3 types of modalities. One is diagnostics, the other is prevention, and the last one is treatment. And all 3 areas is making significant impact, but the one that's the most commonly used currently clinically is the diagnostics. Some of the basic concepts of AI are depicted in this slide. A detailed discussion of each of them is beyond the scope of today's presentation, but suffice to say that the bottom line is the computer programming concepts, which is input and output. Also, knowledge engineering has increased significantly as far as AI is concerned, and this is a very, very advanced field within the AI. The automated planning of software is actually becoming more important now, especially with the unsupervised learning and the execution of tasks. And that is one of the areas where we can really utilize this in healthcare, especially in diagnostics planning. Next, we have computational learning, which is purely machine learning category. And think of that as an advanced statistical technique with the computing power. And that's the one that's implied in most of the papers published already in artificial intelligence in healthcare. And we're going to talk a little bit more about it in the next few slides. Then we have natural language processing, which is something that we've been using in radiology department for dictations and for others, for example, Dragon training and other softwares for a long period of time. And Siri in your iPhone and others are examples of natural language processing. Then we have another newer concept called social general intelligence in AI. I'm not going to go into detail because that's relatively new and it carries a lot of discussion, but that's a field that's upcoming and may have an implication in the bioethics as well. On the right hand, you will see that the most common utilization of AI in healthcare is on machine learning, especially a technique called neural networks. And you would quite frequently hear the terminology deep neural networks or convoluted neural networks, and that's actually this programming within the machine learning paradigm. And the other one that's very common, I already described, was NLP, which is natural language processing. Now let's shift gears towards what's happening currently in the world. This is a paper published 5 years ago in 2017, looking at the publications then in peer-reviewed journals of AI. And as you can see, cancer dominates the picture. Fast forward another 4 to 5 years, currently cancer and transplantation is quite dominant as far as progress in AI is concerned in healthcare, cardiology, radiology, neurology, and other also fields in which it has made significant advances in practically every field. But when it comes to cancer, you're talking about radiology and pathology mainly. So there have been a lot of breakthroughs in AI. Before I go into
You are currently the
stem cell
only person in this
transplantation, I just
conference.
want to show you 3 papers which actually have changed the spectrum of how we think about AI in the world. One is skin cancer diagnosis, the other is retinal diseases, and the third is breast cancer. Now let me start with the melanoma image recognition. Stanford investigators compared thousands and thousands of images, actually more than 130,000 images of the skin tumors, and devised a program based on neural networks to actually recognize the images and then classify them according to the correct diagnoses. And for this, they had 21 board-certified dermatopathologists also looking into the same slides for a classification of diseases. Obviously, this required a huge amount of work for annotations, but as you can see that the classification, the predicted labels by the CNN, which is convoluted neural networks, was much better than dermatologists. In fact, all dermatologists combined, indicating that the machine learning softwares can really read the biopsies, but also predict them accurately what they are, and classify that so that rapid action can be taken. And typically the way it works is actually you classify them, annotate them, and you have a decision tree given on the left, which is skin disease, benign, malignant, or it's actually within malignant, you can have different categories and then subcategories and subcategories. So pretty much typical decision tree classification based on machine learning software. So this really changed the thought the world thinks of machine learning softwares in diagnosis of cancers, especially skin cancers. And after this paper, this was in 2017, a lot more progress has been made already with respect to skin diagnoses. The next breakthrough that came in was predicting wet age-related macular degeneration using deep learning softwares. Now, this study is important because the AMD is one of the leading causes of blindness in the developed world. And if you diagnose one eye having AMD, there's a very high risk of that the other eye is going to also have AMD or progress to AMD and cause complete blindness. Now, we need a prediction system in order to intervene so that the other eye doesn't get blind. And that's what they did actually. These investigators looked into models of 3D OCTs. OCT is the optical coherence tomography, a quite common procedure, pretty standard of care in many ophthalmology clinics. And they mapped the macula, the retina, and looked into the devising a program which was self-learning so that it can predict the AMD in a 6-month window going forward. And that's how they did it, in fact, that once the wet AMD was diagnosed in first eye, patient was referred for evaluation to ophthalmologists for the intravitreal injections. But actually the images formed the database, which is a big data, to model a program which can read and predict whether the other eye is going to be going ahead with AMD as well. What is the actual conversion risk? And this is a methodology given over time on the left-hand side for the fellow eye based on the OCT readings. And on the right hand, you can see actually that the months since progression was accurately predicted by this methodology. And this is important because this was actually achieving AUCs, which were 11% better than the ophthalmologists combined compared to the machine learning. And that thereby you can intervene early if you had this kind of software. Now, breast cancer screening is a big one. This is an important study published in Nature just last year. It looked into the images of mammogram screening from the United States and the UK, and it had a huge amount of NHS data. Now, the breast cancer screening is a little different in US versus UK because of the time interval of screening, for example, 2 to 3 years in UK versus 1 to 2 years in US. But if you had both the images and data sets from US and UK, here it's given 25,000 from UK and 3,000 from US. Typically what happens in the UK, you have a double reading of the mammograms, and there's a follow-up as well, and the number of cancers diagnosed over time are much less because it's an infrequent event, 1.6% in UK versus 22%, about a fifth in the US because of the screening interval. But if you had a software that could read and predict the cancer risk over time, then you really would reduce the lead time bias, but also intervene early in some of the cancers. So, and when they actually made this kind of independent model based on deep neural networks, versus 6 radiologists not only was extremely accurate, but also was much faster and cost efficient. For the second reader of the mammogram, this study clearly showed in real world it can decrease the time taken for the second reader by 80%, which is a huge savings as far as time is concerned, and obviously cost is concerned as well. But let me show you something interesting, that the top 2 images are showing a small breast lesion which was missed by all 6 radiologists. And these are world-class radiologists who were only reading mammograms and extremely experienced ones. But the machine learning software picked it up. However, on the contrary, there's nothing perfect, because on the bottoms, you would see actually that this breast had a breast cancer which was read accurately by all 6 radiologists. And it was missed by the AI algorithm. So just telling you that none of the machine learning algorithms are perfect. The beauty of the AI algorithms is that anytime it identifies a mistake, or you actually do the input that this is you annotate a new finding, it can self-learn and become perfect and better and better. So that was just 3 of the many studies that have changed the spectrum how we think of AI into 2021. I'm going to shift gears towards stem cell transplantation. This is a very nice study done by our colleagues at NMDP in Minneapolis with collaborators, indicating that, when you call for a donor for a stem cell transplant for allograft, a lot of donors are unavailable. And how can you predict which ones are going to be unavailable, and what are the causes of that? And they devised a very nice machine learning algorithm which can predict that these are the important causes based on which the donor may be unavailable. Now, this is important because currently we have approximately 14 million donors worldwide in all the registries, which pour into WMDA. This includes Anthony Nolan, NMDP, which is Beat the Match, DKMS, EKRD, and many others. So very nice algorithms for donor availability prediction, which is important for time factor for our patients who need an allograft. Now, Jocelyn Gandelman, along with Madan Jagasia and many others at Vanderbilt and nationwide in the US, looked into the chronic GVHD consortium data and put in machine learning techniques which would actually classify different graft versus host disease clusters, because not all of them have the same overall survival. And and this is what all of us see actually in BMT, that not one patient comes with only like chronic GVHD, which is uniform. They have more eye involvement or lung involvement or GI tract or skin musculoskeletal fascia. Now, when the actually machine learning algorithm looked in training and validating sets, it predicted 7 different categories with distinct outcome. And here in this graph, you're seeing the probability of being GVHD free over time. And the cluster 2, which is depicted in this graph in purple with joint and fascia involvement in sclerosis, had an extremely different outcome compared to the mouth and liver. Similarly, somebody having ocular and oral and vaginal GVHD may have a very different outcome. And this, I mean, begs you to think about treatment of these clusters may be different because of different outcomes. So maybe we're not treating them well. A very nice study by Catherine Lee. She's a Harvard catalyst in Boston. She looked into graft versus host disease, acute grade 3 and 4 at 100 in about 10,000 patients from CIBMTR data. And clearly there were 3 distinct categories: low, medium, and high risk. And this is, I think, we think of treatment purposes based on this data, because the treatment paradigm of these group categories will be very different. And you may even preemptively treat, like we preemptively treat CMV. So this was based on machine learning algorithms, which could do thousands and thousands of computations within one regression, for example, analysis. I'm just giving an analogy that multiple variables can be put into one equation where cross-validation and cross-folding with deep neural network techniques, and you can come up with beautiful classification of different groups for a particular outcome. Ronnie Shuval published this paper in 2015, and this is 6 years old, looking at the eBMT data, thousands of patients data, and clearly the overall survival was very distinct based on 10 out of 20 variables that machine learning looked into and predicted survival. And that's how we should think about it. And maybe we should think about the survival based on the machine learning techniques when you see the patient first, rather than thinking, okay, look at the gender and CMV and the donor age and the HLA mismatch, the degree of HLA mismatch and the disease status, maybe all of them put together, and then you can get a very refined outlook for the survival. And this is another multiple myeloma predictions for relapse. And this beautiful study looked into many different factors and came up with some risks which were not considered to be the top risk for the PFS predictions. And you can see the check one, low and high, was really a game changer as far as predictions concerned with respect to transplant. I mean, I don't even think of this when I'm looking at myeloma patient for autologous transplant, but clearly there's a lot of things we were missing with machine learning algorithms can connect many dots together. Basically, they're doing hundreds or thousands of regression analysis between different variables to predict, okay, these are the variables that are important for this particular patient as far as the outcome is concerned. So it's a truly personalized medicine. So let's just conclude by indicating that where are we going now? And in Saudi Arabia, Gulf countries, and many other countries in the world, people look into the approvals for the drugs or softwares or devices in the US or EMA, and then they start approving in their countries. And I've seen this because I live in this region, whether it be any drugs, in fact. So first question is US FDA approved? And the question is, when are we going to see the first AI technology approved by the US FDA for clinical use, not for research? And the answer I get sometimes is 5 years, 1 year, 2 years, this year. And sometimes it's the people always saying never. There's always people who have anti-AI mentality and want to indicate this is never going to happen. When in reality is, this is a paper from September of 2020, indicating about 60 softwares that are already FDA approved and current clinical paradigm use because FDA has approved them. And 29 were on the FDA website that they have given in the table. As you can see, a lot of them are oncology and cardiology, neurology, but suffice to say that majority of them are looking at image recognition techniques, which may be TensorFlow or others, but basically they're looking at diagnostics, not for therapeutics at this moment. And to conclude, I mean, the radiology is by far the largest area in which the techniques have been very successful in predictions. And within radiology, cancer comes at the top. And we are living in a tech world. I mean, this is 2016, and 5 years down the road, this has changed dramatically in the favor of technology that, 20 years ago, things were different. Even in 2006, 15 years ago, ExxonMobil, GE, and many others like banks were BP, Shell, PetroChina were leading the world as far as companies, as far as value, the market share is concerned, not by revenues or assets. I'm talking about market share purely. And things change right away towards the companies because of a reason that they rule the world because of the way they have incorporated in our daily life, whether it's cell phones or whether it's other applications in a hospital. So we've got to think about AI, in fact, for everything. I mean, you think supply chain, finances, billing, coding. Yeah, so, but the limitations are many. Some of them I enlist here: technical faults, social financial costs, and maintenance costs. Privacy issues are significant. Cybersecurity is a huge area of discussion. We're publishing papers on that. And then emotional deprivation, absence, limited novel idea generation, and insurance issues as well. So the take-home message is being that AI is being refined to help us and not to replace us. And it can help in time efficiency, accuracy in diagnostics, precision medicine, cost savings. And it's already shown to classify groups of patients with high and low risk of acute GVHD as far as BMT is concerned, and also clustering chronic GVHD. It can also help us in donor availability prediction. And already many FDA-approved softwares are currently in use for diagnostics. So it's just a matter of time before we actually get into this. So today, all of you have to decide where you want to be in this graph. This is from marketing, obviously, but this applies to every single field. You're innovators, early adopters, early majority, late majority, or laggards, or actually there's people who never want to change at all. I mean, and the people who are early adopters take the big pie. The innovators actually become billionaires, as some of you want to be, but really, if you don't be early adopters, it's been there for decades now, the field, but over 10 years, it has significantly increased. So if you don't enact it now, maybe we're either going to be late majority or laggards. So it's time for us to think about this seriously and put it in clinical practice to help us. And with that, I want to thank all of you and think about something that's going to help us, not replace us, in the framework of a proper bioethical cybersecurity network. With that, thank you very much for listening to me, and happy to entertain questions or discussion.